Hello, everyone, and welcome. My name is Helena Leal Pujol, and today I'll be presenting the defense of my bachelor thesis titled A Physiologically Based Model of Pravastatin, the Role of Genotypes and Hepatic or Renal Impairment on the Pharmacokinetics of Pravastatin. Cardiovascular disease is one of the leading causes of death around the world. One of the major risk factors for it are the elevated plasma levels of cholesterol, that is, hypercholesterolaemia. However, hypercholesterolemia can be treated by using a class of medications capable of inhibiting the activity of the HMG-CoA reductase, a major enzyme in cholesterol biosynthesis. And these medications are called statins, and within this work, the focus lies on pravastatin and its pharmacokinetics. So the question arises, why is it of interest to develop a physiologically based model or a PBPK model on pravastatin pharmacokinetics? A possibility to apply such a model would be to investigate the effects of genotypes of enzymatic transporters, as well as hepatic and/or renal impairment on the pharmacokinetics of pravastatin, so that ultimately questions regarding pravastatin therapy can find an answer. For example, how would pravastatin therapy be affected in renal or hepatic disease? As well as, how should pravastatin therapy be adapted to patients based on genotypes? Answering these questions would be beneficial to be able to individualize statin therapies. A computational model can provide answers to the previous questions. In our case, we developed a PBPK model consisting of various defined compartments, which allows to study the pharmacokinetics of pravastatin, as well as to predict its ADME kinetics. And what is meant by pharmacokinetics are the changes of the drug concentration in the body after its administration due to absorption, distribution, metabolism, and elimination, which is what ADME refers to. And for pravastatin, that would be the absorption through the intestine and subsequently into the liver, the low metabolization in the liver, followed by the excretion into either the bile duct or into the urine via the kidneys. More on that in the following slides. And based on these time courses, which we see an example here on the right, we can calculate pharmacokinetic parameters, which are enlisted here on the left. And then these parameters are used to evaluate liver function. And these parameters are, for example, maximum concentration or elimination rate or area under the curve, and so on. So the aim of this thesis can be subdivided into various aspects, such as the development of the aforementioned PBPK model of pravastatin, the analysis of the effects of hepatorenal impairment on pravastatin pharmacokinetics, as well as the effects of genotype on pravastatin pharmacokinetics, and lastly, the application of the model to clinically relevant questions. And so here on the left, we see the whole body model, and on the right, we see the tissue models. And ultimately, what was done here was to construct the whole body model in a hierarchical manner, which consisted of the whole body model being coupled to these tissue models, which are the liver, the kidney, and the intestine. And what we can see here in the whole body model is that the systemic circulation connects the arterial blood with the venous blood, and that pravastatin is transported in the various bodily tissues. Differences in oral and intravenous administration can be seen as well. For instance, when applied orally, pravastatin is isomerized into its metabolite in the stomach, and the intact fraction of pravastatin will reach the intestine, and from where it can either be excreted directly into feces, or it can be actively transported by OATP2B1 into the portal vein, and subsequently into the liver via OATP1B1. In the liver, pravastatin is almost not metabolized, and it does its inhibitory activity on the HMG-CoA reductase. And from there, pravastatin can be either transported into the venous blood via the hepatic vein, or it can undergo enterohepatic circulation. That is, it will become excreted into the bile duct via MRP2, so that it will reach the intestine anew, and this process will be repeated anew until there is no pravastatin left in the body. In contrast, when pravastatin is applied intravenously into the venous blood, pravastatin becomes distributed through the lung into the arterial blood and then into the bodily tissues. And so once the model was established, we wanted to evaluate its performance. So in order to do so, the model predictions were compared to data from multiple studies under various dosing protocols. So what we see here are example simulations for a single oral dose, for a multiple oral dose, and for an intravenous dose of pravastatin administration. And the dotted lines represent the curated data from each respective study, and the solid lines are the time course simulations predicted by the PBPK model. And we can see that overall, the curated data and the predicted time courses are in good agreement with one another due to parameter fitting, improving the agreement between study data and model predictions. And the large error bars in the left panel can be attributed to the relatively low sample size in the study and the large inter-individual variability. But again, the overall dynamics are captured well by the model. So in order to give context to the following slides, it's important to take into consideration how several degrees of hepatic and renal impairment affect the liver and the kidneys, respectively. So regarding the liver, we understand that it plays an important role in the elimination of pravastatin. Hepatic impairment describes insufficient liver function, which can be either caused by liver injury or liver disease. And one example of liver disease would be cirrhosis, which is characterized by intrahepatic shunts of the total liver blood supply and hepatic tissue loss, which is depicted here by this figure. And therefore, a major fraction of pravastatin is not able to reach the liver, and the liver has a reduced effective volume for the elimination of pravastatin. And consequently, the pharmacokinetics of pravastatin could be affected. So the child-Turcotte POG, or the CTP scoring system, indicates how severe the cirrhosis is. So class A indicates mild cirrhosis, class B indicates moderate cirrhosis, and class C indicates severe cirrhosis. Onto the kidneys. They are also important for the elimination of pravastatin. And an example for renal impairment would be chronic kidney disease, which results in progressive renal function failure. And kidney function can be measured using the glomerular filtration rate, or GFR, or creatinine clearance, CLCR, which is an estimate of GFR. And it suffices to say that with increased renal impairment, renal clearance is going to be reduced, which is depicted here in this figure. And in patients with normal renal function, the GFR amounts up to 90 milliliter per minute per 1.73 square meters or higher. And as renal impairment becomes more severe, the GFR is significantly decreased, as shown here by this scale. So with that information in mind, we wanted to see if the model was able to simulate the effect that various degrees of renal impairment had on the pharmacokinetics of pravastatin. So depicted here on the right are the time course simulations for the different tissue compartments. So that is plasma, urine, liver, bile, and feces. And they illustrate the effects of the various degrees of renal impairment. So the blue lines represent increased function, the red lines represent decreased function of the kidneys, and the black line is the control value. And basically what we can see here is that with increasing renal impairment, pravastatin in plasma, bile, and feces increase, whereas urinary excretion of pravastatin decreases. And here we see the effect of renal and additional hepatic impairment, which is highlighted here by the blue axes. So from left to right, the columns represent increased severity of cirrhosis ranging from control, that is from healthy to severe. And we clearly see that any degree of cirrhosis ranging from mild to severe has a very strong effect on the pharmacokinetics of pravastatin. And so we see that the model was capable of predicting the effect that various degrees of hepatic and renal impairment have on the pharmacokinetics of pravastatin. And an additional effect that we wanted to analyze with our model was how the individual pharmacokinetic parameters of pravastatin depended on both hepatic and renal impairment. So here we see the dependency on cirrhosis on the individual pharmacokinetic parameters of pravastatin. And the green lines represent the additional effect of renal impairment ranging from control, which is represented here in black, and from mild to severe in the shades of green. And we can see that AUC and Cmax show a large dependency on the severity of cirrhosis, as well as the severity of renal impairment, meaning that the worse the renal impairment and the cirrhosis are, the greater the AUC and the Cmax will be. Then in regards to the half-life of pravastatin, it's not affected much by neither hepatic nor renal impairment. And then in regards to clearance, we distinguish between total, hepatic, and renal clearance. And for total and hepatic clearance, we see in the steep decreases in function that they are clearly affected by cirrhosis. However, they do not seem to be impacted by renal impairment. And in turn, we can see that renal clearance is greatly affected by renal impairment, but not by cirrhosis, which really makes sense since the kidneys are impaired, and so will the renal clearance. And since renal clearance only contributes about 10% to the total clearance of pravastatin, only a minor effect on the total clearance can be observed, since the liver is able to compensate for the renal impairment. However, in regards to renal clearance, data was indeed very limited, and we still wanted to see the effect that the renal impairment had on renal clearance. And so for the model's validation, we looked at data from Halstensson's study in 1992, which was the only study to report values for renal clearance. And then we proceeded to simulate that with our model. And so what we see here on the two panels on the left are the plasma pravastatin concentrations, as well as a simulation for the amount of pravastatin excreted in urine. And here the predicted changes in urinary excretion of pravastatin with renal impairment are in good agreement with the data, although the reported urinary excretion amounts are twice as large as the model's predictions. And then the two panels on the right illustrate the comparison between the dependency of renal clearance on renal function and the dependency of renal clearance on creatinine clearance. And these panels were simulated for various degrees of renal impairment described by the various shades of green, and the model's prediction stands indeed in very good agreement with the curated data, as it predicts an almost linear increase of renal clearance with increasing renal function. So again, in order to better understand the context in the next slides, we can take a look at the effects of the genotypes, since they have an influence on the pharmacokinetics of pravastatin. So beginning with OATP2B1, it's commonly expressed by gene SLCO2B1 at the apical membrane of enterocytes, and it is responsible for the absorption of pravastatin into the enterocytes within the intestinal lumen. And the uptake of pravastatin has been observed to be pH dependent. So most genetic variants of enzymatic transporters are due to single nucleotide polymorphisms, or SNPs for short. So basically SNPs in SLCO2B1 result in alterations in the enzymatic activity of OATP2B1 when it's expressed, and consequently on the impact that an SNP would have on the pharmacokinetics of pravastatin. However, the information on OATP2B1 SNPs remains very limited to this day. So next is OATP1B1, and it's expressed by SLCO1B1 at the basolateral membrane of hepatocytes, and it actively transports pravastatin from the portal vein into the liver. And so again, these SNPs results in changes in the enzymatic activity of OATP1B1 and thus altering the transport of pravastatin as well as its pharmacokinetics. And lastly, MRP2, which is an enzymatic exporter, which is expressed by ABCC2 at the apical membrane of polarized cells, such as hepatocytes. And in the liver, MRP2 exports pravastatin into the bile. So SNPs in ABCC2 may alter the enzymatic function of MRP2 and pravastatin pharmacokinetics as well. However, this information remains very limited and further research is required. So here we see the validation for genotype scans, specifically for OATP1B1. And here we were mostly interested in the impact that an SNP may have on the pharmacokinetics of pravastatin. And we wanted to see if the model was able to accurately predict the effect of an SNP on the genotype and on the pharmacokinetics of pravastatin. So what you can see here is the comparison between the model simulation, which is here the panel on the left, and the study data reported in the studies shown in the legend, which are depicted in the panel on the right. And the model predicts that a genotype resulting in decreased OATP1B1 function, which is here depicted in red, will result in an increase in AUC and plasma pravastatin concentration, whereas an increase in function, which is here depicted in blue, will result in a decrease in AUC and plasma pravastatin concentration. And comparing the model simulations with the data, we can see that the effects of the SNPs on the genotypes reported by the various studies could accurately be represented by the model. So we see here that the black line corresponds to the, well, almost invisible black line here, and SNPs with a decreased function correlates with the red simulation line, as well as the blue line, which correlates with the blue lines. And here the same idea applies. So we want to see if the model is able to predict the effect of an SNP on pravastatin pharmacokinetics. And this time we wanted to see the effects of the SNPs in MRP2. And again, we have a comparison between the model simulation and the study data, which was quite limited for MRP2. And what we can see here is that the model predicts an increase in pravastatin plasma concentration and AUC for increased MRP2 function, which is illustrated by an almost invisible blue line, and a decrease in plasma pravastatin concentration and AUC for reduced MRP2 function, which is described by this red solid line. And this stands in line with the experimental data, where we can see that the black dotted line representing the ABCC2 wild type correlates with the black control line in our simulation, and the red dotted line from the data correlates with the solid red line from a simulation, which describes decreased MRP2 function. So overall, we were able to develop a PBPK model, which was able to, one, predict the pharmacokinetics of pravastatin given hepatic and/or renal impairment, as well as to analyze the effects of genetic variants of only OATP1B1 and MRP2. And of course, there were some limitations while developing the model, for instance, that the data for liver function, renal clearance, and genotypes, for example, OATP2B1, was indeed very limited, making it difficult for modeling. Nevertheless, these data were used to evaluate model predictions, and they were generally in good agreement with the data. So the question arises, what are possible outlooks for the present PBPK model and how it could assist in future research on pravastatin pharmacokinetics? And one possibility would be the modeling of drug-drug interactions, especially in the elder population, since they are often prescribed with multiple drugs in addition to statins, and thus polypharmacy therapy could be better adapted. And another use case would be the application of the model to study the effects of the circadian rhythm on pravastatin therapy, since adapting the time of application of pravastatin could optimize treatment effects. And lastly, the pharmacodynamic effects of Pravastatin could be modeled to further study the lipid-lowering effect of cholesterol, which could be useful for future research. And lastly, a big thank you to Dr. Matthias König and Jan Grabowski for their great support throughout my bachelor thesis, their patience while guiding me through data creation and model development. I'm very thankful. Thank you a lot. I enjoyed the project. I learned many new things. Thank you. And with that, to all of you, I say thank you very much for your attention, and I'll be happy to answer any questions you may have.